A very good afternoon, everyone. We welcome you all on behalf of Haryana ISAR to our second episode of Up to Date with Updates. This is our sincere endeavor to discuss recently published literature and also to update our knowledge time to time. Firstly, our heartfelt thanks to President ISAR, Dr. Ameet Patki sir, for giving Haryana ISAR this opportunity. And it's our pleasure to involve all the young ISAR brigade as well on to up to dates with updates. I would also like to thank and welcome our General Secretary ISAR and expert for today, a very dynamic and vivacious personality, our Dr. Asha Baxi ma'am. We welcome you, ma'am, who's always a source of inspiration, and we are ever thankful for her guidance. I would like, before we start, I would like to invite Asha Bakshi ma'am for her little words of wisdom.
Hi everyone, it is really nice to be on this platform, and I can see that Haryana chapter is really very vibrant chapter with lots of new ideas, newsletters, and all the programs are really excellent. So you people are really doing great job, and I'm so happy that you are so much involved even in latest updates and all. And today it will be really nice to go through all that would enrich our knowledge and help us in our day-to-day practice. So instead of wasting time, let's get going. Thank you. Thanks, Jyoti. Thanks, Meenu. Thanks, Manju and Lakshmi. All of you great. Thank you so much.
Thank you. Thank you so much, ma'am, for joining us today despite your busy schedule. Thank you so much. We now move on. So today, friends, we would be discussing two articles. The first paper that we are discussing is on low serum AMH, the link with poor semen quality in infertile men. That is a randomized control trial that we would be discussing first. And the second one is on evaluating the prognosis in unexplained infertility. So for the first topic, I would like to invite Dr. Manju Dagar. Could I have the CV? So Dr. Manju Dagar is again a very dynamic personality, very integral part of Haryana ISAR. She is our clinical secretary, Haryana ISAR. She's also the director for Nestling Gynecology and Fertility Center and ex-head of the Department of W. Pratiksha Fertility and IVF Center in Gurgaon. So we welcome you, Dr. Manju, and over to you for your presentation.
Thank you, Meenu. Thank you so much. Thank you, ma'am, for giving me the opportunity. So, diagnosis of unexplained infertility. What is the importance of this article to discuss? The diagnosis of unexplained infertility presents a dilemma as it signifies both uncertainty about the causes of infertility and potential for the natural conception. Both we are carrying together in unexplained infertility. So immediate treatment for all would result in overtreatment, and the prediction model estimate the likelihood of the natural conception and subsequent live birth can guide the treatment decision. Objective is to evaluate if couple with unexplained infertility prediction model are effective in guiding us the treatment decision, whether they are effective in guiding us or not. So evidence review, we have studied in this article 25 studies, including all RCTs and prospective studies, and we validate all with internal and external validation and impact analysis, and we reached to the conclusion in this article. So unexplained infertility is defined as the absence of conception in the couple who had tried more than 12 months of the unproductive intercourse. Initial diagnostic workup will focus on three main components needed for the conception. One is egg, second is sperm, and third is the tube that bringing the two together. The main causes underlying is the egg factor or an ovulation, the oocytes that are present but not available for the ovulation or fertilization. Advancing age for the woman resulting in poor oocyte quality is also the factor that is included in the egg factor. Sperm factor is related compromise sperm production or obstruction in the transport of spermatozoa. And these can be initially assessed with single or repeated semen analysis. Third factor is the tube, that is the transport, bringing the egg and sperm together. This can be compromised by sexually transmitted infections, intra-abdominal pathology, including tubal occlusion, endometriosis, and severe adhesions. So diagnostic workup includes assessment of the ovulation and quality of the egg. Normal ovulation can be confirmed by menstrual regularity. Urinary LH we can measure. We can do ultrasound for folliculometry and mid-luteal phase progesterone measurement. These all are the tests that we can that guide us whether the female is ovulating or not, or whether the egg is available for the fertilization or not. But the latest guidelines from the ASHRAE is that if the female has a regular menstrual cycle, then there is no need of evaluation for the ovulation. Diagnostic workup for the second part is we need to assess on the normal semen analysis. 1 or 2 semen analysis with normal parameters. But we check in the semen analysis, we check with the volume, we can check the concentration and total count, motility, vitality, and morphology. Third factor is the tube that can be confirmed. The patency can be confirmed by the hysterosalpingography or hysterocontrast sonography. So although there is a lack of agreement between the one-sided patency is enough to diagnose unexplained infertility, or bilateral patency is most widely adopted criteria. So the one-sided is also included in unexplained infertility is a debatable, but mostly the studies include bilateral tube should be patent to label as unexplained infertility. Last is the transvaginal sonography should be done to confirm normal uterus and excluding the other intra-abdominal pathology, congenital abnormality, and myometrial abnormalities. Diagnosis of unexplained infertility requires at least normalcy of the above test. So above we test about the egg, sperm, and tube, all should be, and the ultrasound should be normal. Of course, this diagnosis depend on the number of tests. More the test we perform, less the diagnosis of unexplained infertility becomes. If additional tests are abnormal, like if we do laparoscopy, though it is not included in the diagnosis of unexplained infertility, but if we do and showing adhesions or endometriosis, infertility is no longer explained. So we can establish the cause. So this no longer it's an unexplained infertility. The diagnosis of unexplained infertility bring a dilemma. On the one hand, the couple is experienced the individual disappointment of trying to conceive for 12, 18, and 24 months without any success. This gives from individual perspective the perception that pregnancy will never happen, especially because other couple in their direct proximity quickly conceive. On the other hand, the lack of the clear factor prohibiting the conception implies that pregnancy can occur at any moment in these couple. Indeed, approximately 50% of the couple who try to conceive in vain. And for the 6-month natural conception occur, and in next 6 months they conceive. And in the second year, 50% of the couple will conceive naturally. Though on individual level, a couple experience infertility, but at the same time, on population level, many natural conception will occur over the time, indicating that subfertility may be better than the infertility. The diagnosis of unexplained infertility brings a double message. On the one hand, uncertainty about why the pregnancy is not happening. And on the second hand, fact that the absolute factor for hampering the conception is not present, so pregnancy can happen at any time without any treatment, and the prognosis is usually good. So we can see the unexplained infertility like a glass is half full and half empty. If it is half full, there is nothing abnormal, and this is reassuring. Half empty, that is no identifiable reason why conception is not occurring, and this is frustrating. The consequences of unexplained infertility target no specific cause of infertility is found. So where we target our treatment. Like if patient is suffering from anovulation, no egg is a patient is suffering from anovulation, so we can target the ovulation induction, or in IVF by we can bypass the tubal occlusion. The treatment of unexplained infertility does not have any such analogy and does not have any cause. So when to start, where to start, what to target is unexplained. The treatment in unexplained infertility therefore tries to increase the probability of success by increasing the number of chances per cycle. How we increase these chances? We can increase the number of oocyte available in IUI, and we can target creating multiple embryos in one IVF cycle so that we can increase the chances of success per cycle. Prognosis of in unexplained infertility. In deciding when to start the treatment And when to start the treatment in these cases, prognosis should be instrumental. So clear causes of fertility such as anovulation or bilateral tubal blockage reduce the natural fertility chances is almost zero. In unexplained infertility, this is not the case. The prognosis of natural conception add insight. The main prognostic factor for natural fertility is obviously the age of the female partner. Female fertility starts to decline slowly after the age of 30 and decreases. Though there are individual variations are present in this, exponentially decreases after the age of 37. Other factors contributing to this prognosis include duration of the infertility. As duration is more, the chances of the prognosis is poor. Previous conception. If there is a previous conception, the chances of conception prognosis is good. Semen quality, body mass index. If there is a BMI is more, then chances is less. So the best way to integrate these components in the prediction model. So model development, how we derive a model to predict the prognosis in these cases. So there are three phases to develop a model, prediction model for calculating the prognosis in unexplained infertility. One is model derivation. So what include in model derivation is we should find out the predictive factor. So that we can put these predictive factor, we can understand on the basis of prior knowledge and understand the biological mechanism after which it is determined if the predictive factor independently contribute to the prognosis and should be included in the model at what weight as expressed by the regression coefficient. Second factor is model validation. So model validation is in model validation process, the model's ability to predict outcome is evaluated. And how it is evaluated is evaluated by two fundamental dimensions. One is predictive performance or the discrimination, and second is calibration. So discrimination express how effectively the model distinguish between the individual who will and will not experience the event of interest. And what is the interest in this case? That is conception to leading to live birth. Time to event scenario, it assesses the model's capacity to predict whether the individual will experience the event, whether the individual will experience the pregnancy or live birth sooner or not at all and as compared to the others. Discriminative capacity usually expressed as the area under the receiver operating characteristic curve or the concordance index. So concordance index is a very statistical popular parameter from where we can predict the two value, that is predict and observed value, we can concord and we can say how effective is the model. Calibration refers to the agreement of the model's prediction in aligning with the observed event rates overall. Although discrimination express how successfully a test can order these and those without the event. Calibration refers to the agreement between the estimated and observed. For example, I estimated the prognosis 30%, but what I observed out of the 100, I observed 20%. Then what is the concordance value? What is the calibration value in these cases? So how we calculate the calibration and C value. Calibration is assessed for far less often than the discrimination. But in contrast, the prognosis of unexplained infertility, probably calibration is more important than the discrimination. Various statistical methods can be employed to evaluate these two metrics. So this is the model that we can calculate the discrimination and the calibration. And the first graph A is evaluating the discriminative value. In this case, discriminative capacity of the model expressed in receiver operating characteristic analysis. And this model discrimination value is an area under the curve is 0.6. That is indicating poor discriminative capacity. What is the good discriminative capacity? More than 7 is 0.7 is good discriminative capacity. So calibration of the model is calibration plot indicate to what extent the prediction and observed chances concur. In this case, if we see the x-axis and y-axis. In x-axis, there is a predicted chances, and y-axis observed chances. So what we predicted for that couple and what we observed in those couple. So we can see these in there, and this mean predicted chance is never more than 1.5% different from the observed probability. So this is all explained. The show that figure that curve A that shows that a ROC curve expressing the discriminative capacity of the model. The ROC curve expresses the sensitivity specificity combination with a 100% sensitivity, 100% specificity, expressing the perfect accuracy at which all couple achieving pregnancy can be separated from all couple not achieving pregnancy. A perfect sensitivity of 1 at the upper left corner is unattainable in real setting. Hence, the model typically meets the expectation when area under the ROC curves fall between 0.7 to 1. We should not reach at 1. We cannot predict the pregnancy and conception at 100%. So, C index is the area under the ROC of IUI model figure A was 0.56%, that indicate poor discriminative capacity. And the calibration of the same model. The calibration plot indicate at what extent the predicted and observed chances occur. Ideally, a perfectly calibrated model would exhibit a diagonal line represent the perfect agreement, and that is not and here that is not reached. But mean predictive chances is never more than 1.5%. So next is model validation. Validation can be internal, can be external. Internal validation is the validation where this model is derived. The group of the population or group of the patient from where this model is derived and applied. At external validation is the predicted model is evaluated in the population other than the population in which the model was developed. And third and final phase of model validation is the compact impact analysis, which is evaluation of the implementation of the predicted model with documented validity. Impact analysis establish whether the predictive model enhance physician decision making regarding them to treat, when to treat, how to treat, and ultimately leading to the improved patient outcome. This evaluation preferably occurs in context the randomized control trial that are included in this article. So there are 25 trials in this evaluation concept, and in out of which 6 are randomized control trial, rest are prospective study and cohort study. The sample size of the derivation model varied from 224 to 5962, approximately 6000. The predominant type of prediction model developed in most studies Cox regression, taking into the account time of pregnancy, employing either forward or backward stepwise variable selection method, and identify the significant predictor. The most frequent predictor is female age, duration of female fertility, primary or secondary infertility, and percentage of motile sperm. Bostaffe reported solely that these two are the only focusing on the male infertility, reporting on the infertile couple, and found that the duration of infertility, female diagnosis, and sperm penetration test they did to predict the chances of conception. Wichmann et al. Reported 900 men suffering from infertility and their partner, and found that duration of infertility, age of both partner, history of male urethritis, male body mass index, and the series of semen characteristics were significant predictor of infertility. And these are the table of 25 models that they are predicted, and out of these, these models are between 1987 to 2022. Among these studies included 15 derivation studies, 7 are conducted internal validation, 6 external validation, and 4 article reporting on the impact analysis. So there are few case control study. Collins, LLMS, Snickers performed a large scale cohort studies with sample size of 2198, 996, and 726, which were focused on the couple and not on the male partner alone. Female age, duration of fertility, pregnancy history having been pregnant before or not were found to be the most consistent predictor. Prediction score developed by the Collins and Snicker are deemed to have 62% approximately and 76 to 79% accuracy, respectively, assessed via ROC analysis. However, calibration assessment was lacking in both studies. They have only discriminative part, and they predicted 62% probability and 76 to 79% accuracy. AMR model demonstrated strong calibration model under split half validation method, and predicted pregnancy were in close agreement with the observed pregnancy. The Hinald et al. Is then that developed in 1994. The model is developed by, and this is the basis of the all studies. And on the basis of this, the new model is developed. Zekmans et al. Conducted a cohort study in the Netherlands studying the treatment-free ongoing pregnancy among 596 to approximately 6,000 couple on waiting list of IVF or ICSI treatment. So this is in Netherlands is a one. There are 32 centers they included IVF center, and over those IVF centers, 6,000 couples are waiting in the waiting list for IVF or ICSI, and they found female age, duration of age, previous pregnancy, and diagnostic category to be productive. The study reported on the couple scheduled for IVF with a duration of more than 3 years, and absolute treatment-free pregnancy chances were approximately 10%, resulting in low calibration when the model would be applied in the couple first consulting as a specialist. This model demonstrates the discriminative index of 0.65% after correcting for optimism and indicating a 65% ability to distinguish high chances from low chances couple. The low chances couple is they are considering the low chances, they are kept in the IVF ICSI cycle, but they conceived naturally. So in natural conception, in Ping Pong et al., that is also focused on all these parameters and find out that natural conception is contributed to 20% of all live births. So Benstrop et al. Extended the Honald model to predict the likelihood of the natural conception resulting in ongoing pregnancy on more than 5,000 subfertile couple with unexplained or mild male factor subfertility collected by Van de Weng and for their validation study. The revised model incorporated all predictor from the original Henault model. Henault considered 5 criteria to make a model. With an additional 7 variable, woman body mass index, these are the variables: woman body mass index, cycle length, basal FSH, tubal status, history of previous pregnancy in current relationship, ongoing pregnancy after natural conception, fertility treatment or miscarriage, semen volume and semen morphology. What Henault included is the female age, previous conception, referral status, and the previous miscarriages, and after that he calculated the prognosis factor. So, and the sperm parameter he included and duration of fertility he included. Out of these 5, these 7 additional variable they included, the total 12 variables are there in the study. They studied and they evaluated the outcome, and all these are BMI, cycle length, basal FSS, tubal status, history of previous pregnancy. They increased the other predictor also. The revised model showed improved discrimination. C index is 0.7% compared with the Henault model that C index was 0.59%. That is poor, but the revised model shows a good discrimination or C index. Calibration analysis also revealed better agreement with the observed pregnancy rate for the revised model, leading to the reclassification in 39% of the couple, indicating enhanced prediction accuracy. So Righart et al. Assessed the likelihood of live birth in in approximately 1,400 infertile couple in prospective cohort study. And they included extra primary or secondary infertility, socio-economic status, assisted reproductive technology, diagnostic category, and importantly, this model included pregnancy conceived with treatment. So, Jaggard et al. Studied 109 men with infertile couple where the female partner is normal. And they also included fertile sperm and donor sperm. And that 12 parameter comprising broadly 4 semen parameter, they also included concentration, progressive motility, and normal morphology. And they also include a hypoosmotic swelling test yielded a satisfactory prediction of the spontaneous conception. And this prediction model achieved 90% accuracy in predicting conception and 90% accuracy in predicting its absence. So the revised model shows better calibration and stable discriminative ability over the time. The revised model outperformed the Henault model with high C index, that is 0.7% versus 0.5% that is given by the Henault model, resulting in improved agreement between the predicted and observed pregnancy rate and allowing to assess the prognosis after the couple has waited for the treatment for 6 months. Thus, we can do a personalized prediction. Then later on, McLeon et al. Developed a dynamic prediction model. The novelty of this model is that estimated chances of conception after expectant management and different fertility treatment over the time in couple with unexplained infertility. The dynamic prediction model shows moderate discrimination ability, that C index is 0.6 to 0.7%, that is good. Over various prediction month, calibration analysis indicate good alignment between the predicted and observed conception rate, with minor evidence of overestimation at some point of time and minimal overfitting. As described above, many of the model derivation studies are mentioned above incorporated internal and external validation. So C index with internal validation was 0.7%, that was good. But this is also common predictor within the prediction model for treatment independent pregnancy across 25 included studies, mainly are female age, duration of subfertility, sperm motility, type of subfertility, and the referral source have been found to be the most frequent predictor. Notably, rare predictors are omitted from the table of this studies. So these are the studies that they have included in all studies. The female age is included in almost all studies. Age of the male partner included only in one study. Duration of infertility and subfertility almost all, excluding one or two. And detailed pregnancy history, female body mass index is included in many of the studies. Motile sperm concentration and more than 50%. Quality of sperm is also included in 40% of the studies. Sperm morphology is also included in 40% of studies. PCT is in only in 5 studies. And the gynecological disease. And third one is the last one is the female reproductive tract, any infection, male reproductive tract, any defect, and gynecological disease. They included all, and minor they excluded from these studies. And the referral status. So referral status is also included in the most of the latest studies. So what do you mean by the referral status? Referral status, there are two kind of referral status. That is one from the general physician and second from the gynecologist. So the referral status, they give the point that the patient referred from a physician has better prognosis than the referred by the gynecologist. So external validation studies, we identify 6 studies that specifically performed external validation. And these are performed in Canada, Netherlands, New Zealand, Australia, and with sample size of approximately 249 to 3000. Hanaud et al. Performed a validation from the LMS model in 1994 and assessed on Canadian population of the approximately 1,000 subfertile couple planning for IVF with diagnosis of cervical hostility, male subfertility, unexplained subfertility, and validation of the LMR model, which included female age, duration of subfertility, and type of female subfertility. Sperm motility as a predictor. Finding a C index of 0.62 and a good calibration between the prognostic index and the conception within 1 year, resulting in the live birth. So Hanaud model is the base in all of the randomized control trial. The most important model is probably the synthesis of the model of the Hanaud, and that is conducted almost on the 4,000 couple. This model was externally validated in Dutch study, and it was further studied by Dagar validation. Much more importantly, the calibration of the model was excellent, with just over 30% of the couple having an expected successful conception rate, 30%, and 30 to 40%, and 20% of the couple having expected conception at 40%. Means 30% of the couple, the prognosis is 30 to 40% that there are chances that couple can conceive, and 20% of the couple expected conception rate is above 40%. And this is better shown in this graph. That is calibration of the prognostic model, natural conception leading to live birth. A calibration of synthesis model according to the Hanaud is evaluated by one debug. The calibration of revised model according to the benchtop, and both figure dashed line. That making the cross, the dashed line shows the predicted and observed values 30% over 12 months of conception rate leading to live birth rate. Both model identify approximately 50% of the couple in which chances of natural conception are above 30%. So the clinical priority access criteria scored correlated reasonably well with the Hanaud prediction score, although the later recommended assisted reproductive technology for 26% more couple, although both score had similar discriminative capacity, and Hanaud prediction model exhibited superior calibration. About half of the couple with unexplained or mild male factor infertility, and 65% of the couple had intermediate and even good prognosis for the natural conception. This demonstrated that the prognostic model could predict couples' chances of natural conception and benefits from they derive from the treatment. So impact studies, how it is effective is we can analyze with the impact studies. There are 4 impact studies. These studies are used for prognosis of natural conception, more specifically with the Hinault model as an entry criterion of these studies. Those 3 studies are randomized between the couple of unexplained infertility or mild male factor. This is the almost same group, to IUI and controlled ovarian stimulation and expected management. Whereas the 4th study compared the IVF versus IUI. The Stecher et al. Randomized 253 couple with unexplained infertility with moderate 30 to 40% chance of natural conception within 12 months of IUI with stimulation or versus expected management for 6 months, and primary endpoint was ongoing pregnancy. So cumulative pregnancy rate after 6 months is approximately 25% in both strategy, like with ovulation induction IUI and versus expected management. At 3-year follow-up, cumulative live birth rate after IUI with with co followed by IVF almost 75%, independent of whether the treatment with IUI co followed by IVF had started immediately or after 6 months. The investigator concluded that couple facing unexplained subfertility and having an intermediate prognosis 30 to 40%, there appears to be there is no substantial benefit from an immediate start with IUI or co. IUI with go. Zafran, Itil, and Wessel performed randomized studies shows that evaluating IUI co versus expected management in couple with unexplained infertility, but their studies were limited to the couple with poor prognosis. Poor prognosis less than 30% over the 12-month period. Primary outcome was cumulative live birth rate and ongoing pregnancy leading to live birth. In contrast to the Steve et al., IUI with co resulting in both studies in significantly higher ongoing pregnancy rate, although 6-month cumulative live birth rate after IUI co were 31% and 33% with the expected management, and Stecher et al. Find 9 and 30. There is a huge difference in these 2 studies. He found 9% with the expected management, 13% with the IUI and co. The finding of these 3 studies confirmed that that the prediction model can have a fertility management, although coupled with unexplained infertility from a diagnostic point of view are homogeneous. The prognostic assessment of the Hinault model shows different approach to the couple that benefit from the immediate treatment with the IUI and co, and the couple in whom period of expected management still result in acceptable pregnancy rate. Of course, the exact moment to start the treatment is subject to the individual preferences of the couple. Although some couple wants to start treatment as soon as possible, other couple might prefer delay in medical treatment. Bensdorf et al. Randomized 602 couples where female partners had an unfavorable prognosis less than 30% for natural conception and diagnosis of unexplained or mild subfertility for male partner. So they divide into 3 groups. One, in vitro fertilized IVF with single embryo transfer, IVF with a modified natural cycle, or IUI with co. The primary outcome was natural conception leading to an ongoing pregnancy. This RCT indicate no benefit from the immediate start of IVF over IUI with co in couple with poor prognosis. With 12-month cumulative ongoing pregnancy rate after IVF and after IUI are same. There are 4 high-impact RCT are also incorporated in the prognosis for natural conception as an inclusion criteria. To summarize, Stecher indicate that the couple with moderate to good prognosis for natural conception, that is more than 30% in 12 months, the treatment with IUI co offer no additional benefit over the expected management. Conversely, in couples with poor prognosis for natural conception, poor prognosis means less than 30% prediction, and good prognosis more than 30% prediction over the period of 12 months. So IUI with co proves to be superior to the expected management as shown in the studies by Wish et al. And Franco et al. Furthermore, as a first-line treatment option, IUI co is found to be equally effective as IVF as indicated by Bensdorf et al. So in diagnostic term, unexplained and mild male infertility is homogeneous group defined by the absence of absolute factor that prevent conception and had with increasing female age reaching to the diminished ovarian reserve. Prediction model can help to classify these couple. In this review, we have shown that these model and in particular with the synthesis of the model of the Henault et al. Are reliable in distinguishing the couples with unexplained infertility with good prognosis for natural conception and that justify expected management from the couple where prognosis is poor and therefore treatment can be offered. So if the good prognosis we can offer and justify the expected management, and when the prognosis is poor we can justify justify offering treatment. In review of 2011, we mentioned several challenges in assessing the prediction model in reproductive medicine. First, there is a debate about performance measure to use prediction model and how to interpret them. Traditionally, we use area under the curve, ROC curve, or C index used to measure the discriminative capacity. We found that discriminative capacity of the prediction model for natural conception is mediocre. So not a very good parameter. But with the C index mostly between 0.6 to 0.7%, this is caused by the fact that the conception cannot be predicted with 100% certainty, with highest prediction rate of approximately 50 to 60%. We cannot predict more than 50-60%. This fact that being in high prognostic category does not guarantee success maximize the C index. But the calibration still can be good. Good is demonstrated in IUI figure. Indeed, we rendered the calibration of Henault synthesis model sufficient for the clinical practice. Second, there is a concern about lack of validation of prognostic model, in particular external validation. Good performance at external validation is minimal requirement to be eligible to the use in clinical practice. External validation means that is the model is applied in different population and we found the consistent prognostic factor, then we can apply in all population and that give the validity of that model, that is efficiency of that model. We found 6 external validation studies performed in Netherlands, Canada, New Zealand, Australia, all reporting adequate discrimination and calibration. More importantly, we identify a series of impact studies in which the Henault prediction model for natural conception is used to guide recruitment for RCT. This allows evaluation of impact of this model on the clinical practice. After confirmation of ovulation and exclusion of severe male factor and tubal pathology, a prognosis for natural conception Henault synthesis model should guide the decision. If probability of the treatment independent of the conception within 12 months is more than 30% independent of the treatment. If there is a no treatment and the probability of conception in within 12 months is more than 30%, the 6 month of expectant treatment should be offered to these couple. For couple, the prognosis less than 30% or infertile couple who have tried natural conception for additional 6 months, treatment with IUI and controlled ovarian hyperstimulation followed by IVF can be offered. We limited this review to the prediction model for natural conception. Obviously, the management of the couple with unexplained infertility can also be guided by prediction of pregnancy after IUI or IVF. It should be noted that many of the predictors for natural conception have a similar impact whether we go for expectant management, whether we go for IUI or for IVF. The some factor like age has a similar risk for all. If age is more than 35, that can impact your natural conception, that can impact IUI, that can impact also IVF. So same impact. So this is the flow chart that is developed in this study. The couple with unexplained infertility, you should check the ovulatory status, check the normal semen analysis. If both are normal, then go for tubal patency test and preferably with the oil based contrast. Calculate the prognosis, that is natural conception over 12 months. If prognosis is good, prognosis is based on that is Henault model. Female age, that is we can give the Henault give a model for all these criteria and give the number. Like for the age 21 to 25 he give the 0, 26 to 31 he give the number 3, and 30 to 35 7, and likewise he gave the number to the duration of fertility also 1 2 3 4. Type of sub fertility he also primary or secondary he gave the number like 0 or 8. Mortality, he all more than 50, 40, 60%, 40 to 50%, 20 to 40%, he gave the number. In the end, final, you take all these parameters, I give the number, add them. If they are more than 30, then you give a good prognostic value. If they are less than 30, then it is a poor prognostic value. Suppose if I give example, a 28-year-old woman with primary infertility, 2-year duration with 30% motile sperm, referred by a gynecologist, has a prognostic index score is 3 for the age, because age is less than age is 20 year. Primary infertility number is given 8, duration of fertility 3, and then total score is 30% motile sperm, give 4. So total score is 22. So likewise, they calculate the prognostic value of this. And if this score is more than 30%, then 6-month expectant management is to be advised to the couple. If after 6 months there is no conception, and if the prognostic index is less than 30%, then we can offer IUI with hyperstimulation, with controlled ovarian hyperstimulation 3 to 6 cycle. If that also not work, then we can offer IVF. Older female age will negatively impact conception chances in all three strategies, thus making it less useful as a treatment selection marker. So there are some negative part also, because we already discussed that age is the most important parameter that negatively impact all strategy of the treatment in conception. Most impact is to be expected from the predictor that have a negative impact on the natural conception, although they do not and only marginally affect the success changes after IUI or IVF. One example is severe tubal pathology, which will reduce natural fertility chances or IUI success rate close to 0, whereas it hardly reduces success chances after IVF. Such treatment selection marker, however, are rare. To optimize the knowledge of treatment on selection marker, we recommend routine measurement of the potential predictor as a baseline characteristics in RCT. The dynamic prediction model by Van Islen et al. Was developed to make prediction repeatedly over any chosen time for expected management. Although it aims to provide treatment tailored to the couple situations, its usefulness for counseling is limited, because the dynamic prediction model leaves couple in uncertain limbo in deciding how long they need to wait until receiving the treatment, whereas Hanaud model assists in binary decision between starting treatment immediately or after 6 months. For the couple with unexplained infertility who tried to conceive for 6 months or more in vain and frustrating, found no identifiable cause, Hanaud model gives a straightforward answer, thus adding the clarity and simplifying the patient's in decision making, both for the patient and for the physician. At the same moment, most systemic review evaluating the treatment do not take into account prognostic aspects. Aikele et al. Reviewed 15 trials involving 2,000 couples with unexplained infertility to compare IUI with timed intercourse or expectant management of unexplained infertility. No significant difference in live birth rate was found between the groups across all the cycles. However, the investigator concluded that treatment with IUI and co probably resulted in higher cumulative live birth rate compared with the expectant management in the couple with low prediction score for the natural conception. Further, future reviews should incorporate prognostic factor, which is possible if the reviews are on the basis of individual participant data. Recently performed such a review incorporating IUI co versus IVF, but this still has to be done with the comparison with IUI versus no treatment. One important clinical characteristic of unexplained infertility is that conception still can occur naturally. As that, it is important to realize that in definition of other categories of infertility, such as male infertility, diminished ovarian reserve, there is no absolute threshold defined in these disease and unexplained infertility. Because it is known that natural conception occurs quite frequently in the couples with mild male factor, with low ovarian reserve also. The strictness of the WHO criteria can be questioned if mild male factor conceived naturally without any treatment. The same is true for the diminished ovarian reserve, where biology allow as a gradual scale rather than the arbitrary cutoff. For clinical practice, definition should be based on the predictive factor or even better established treatment effects rather than on the opinion of the expert or consensus meeting. It is likely some couple currently diagnosed with unexplained infertility have an underlying cause for their infertility, but the current stages of clinical practice and its underlying science does not allow detection of these causes. Like there is a altered uterine contractility that we found in the IVF, and that the altered contractility will hamper our results in IVF. And if we include these criteria also in an unexplained infertility, find out the cause and treatment, then we can uh, find out the cause in unexplained infertility, and unexplained infertility no more unexplained. So dislodging of the debris in the tube can occur through the tubal flushing, thus restoring the normal fertility. In IVF, in vitro fertilization might overcome some of these unknown causes of unexplained infertility simply by passing the huge part of the normal route of the conception. Even though embryos are created, meaning eggs, sperms are normal, fallopian tubes are patent, lot of couples still cannot get pregnant because of implantation failure. Although there is no reliable test so far to prove whether and how the implementation process was compromised, there is a growing body research for this regard. Possibly the knowledge on the cause of implantation failure and tailored treatment to overcome it will later clinical management of couple currently labeled with unexplained infertility will change. For unexplained infertility and its neighboring disease, probabilistic approach as was applied in prenatal screening of Down syndrome before introducing of the almost 100% accuracy non-invasive prenatal testing might be preferable. Randomized control trial should then determine the threshold where the treatment benefit starts, like 30% cutoff for the natural conception in unexplained infertility. Meanwhile, a period of expectant management does not mean that nothing can be done. 6-month window without treatment means the attention should be paid to optimize the lifestyle and to optimize the health to prepare for the pregnancy. So that has not been done yet. If it is not has been done yet, we can do in this expectant management time period. In addition, other fertility promoting treatment, including tubal flushing with oil contrast, can be offered in this window. In conclusion, unexplained infertility is a two-phased condition. Although no treatable cause of infertility is found, conception prospects, both natural as well as after the treatment, are good. Prediction model can help in identifying couple that benefit from the immediate treatment and the couple in whom treatment might be delayed for less than 6 months, as treatment is not adding any benefit to their natural prospects, and we can avoid over treating or under treating, and we can take the timely decision in these cases. Thank you.
Great effort, Manju. It has been really, I'm sure you did a lot of reading. So I think at the moment you are the most, I would say, well-read person about this article. And I want to know one thing, that you have read it in details, and I'm sure you must be having some idea how to use it in our day-to-day practice. So do you think this Honol model that you talked about, can we use it in our day-to-day practice and do the counseling of the patients accordingly? Because if that can
It's very
happen, then that is the
simple.
utility.
Yeah, ma'am, it's very simple. They included five predictive method. One is the woman age. Woman age they categorize into 7 columns, like 21 to 25, 26 to 31, and 32 to 35. And they give the number 0, 3, 7, 10. Like if a woman age is 28, that she can fall into category 26 to 31. So we can give the number 3. So likewise, duration of subfertility, less than 3 year, more than 3 year, they counted like this. Type of subfertility, that is primary or secondary, there is a previous conception or not. And motility part, so good motility, they can categorize it more than 60%, 40 to 50%, 60 to 30 to 40%, like this. They give another number. And the referral status also they give the number, because in their country, one is the primary physician they refer, and one is the gynecologist they are referring. So if the gynecologist is referring, they evaluate and give the treatment in a very effective manner. And
और अपने यहाँ तो self referral भी है, self referral भी होते हैं.
So in these cases, they just give the number and calculate. If this number is more than 30, that means you have a good prognosis. If this number goes less than 30, then it's a poor prognosis. And if if a couple fall in a category of more than 30%, we can counsel the patient and give a good the time period of 6 months to 1 year for the expectant management. 6 months, and after 6 months not conceived, we can offer ovulation induction and IUI. If still not conceived, that give a flow chart in this study is you can offer IVF.
I think this can be used
And
if
it's a
we
very
really,
easy model. We can apply this
because
model.
if we can use Bishop's score before induction of labor, so maybe before deciding what sort of treatment to give, I think one must start practicing using this model. And maybe you need one seal or one chart like thing, and you can ask your assistant or even your nurse to fill it, and when it comes to you, you have an idea. So I think it's very good way of counseling, and it will show how smartly you are working, because these days if you work smartly, that is also a soft marketing skill, isn't it? So that way you can really impress upon the patient about your treatment method. So I think it's a very good thing, and I'm very impressed. You have really worked hard going through the whole paper and bringing out the important points, and excellent.
Okay, ma'am. Thank you so much. It's a difficult paper, but I read all the Henold model, how he developed, and later on how this model is studied in the.
Maybe it's time you start a modified Henold model for Indian. Yes.
This is
Yes.
studied because there is
what I was trying to say, that okay, we have this model, but the only thing we have that referral thing, because we don't I mean, that is something little we should take that out, but maybe other points are considerable in our Indian model. So it should be
Yes.
a modified Henold model that we can follow, and depending on that, how, I mean, whether the patient needs an immediate IUI, COH, hyperstimulation, or then immediately after 6 months should be referred for IVF, or we can leave like some of the infertility patients where we don't find anything, the patients are lost to follow up, and after 6-8 months they come with a pregnancy test positive. It is the same thing, like those, they had a good probability, more than 30%, and then they were left alone to try on their own, and they got conceived without any hyperstimulation, without any ovulation induction and IUI or IVF treatment. I think this is maybe we can just
the basis of
sort
this
of
model, I think,
categorize our patients.
Yes.
Yeah.
the
Very
basis
good.
of this,
Yes, Dr.
nice guidelines were developed. In these studies, they found that there is no difference in success rate in IVF and IUI. That's why the in UK
Yes.
guidelines are like there is no IUI, wait for 3 years and directly start IVF. They are
There was lot of
IVF.
criticism. There was lot of criticism on the NICE guidelines, because they, according to them, if it is unexplained infertility for 2 years, straight away go for IVF. And then this was criticized, and now the papers are coming up in favor of IUI. So that is true. So I think what one can do is we can give the prognosis to the patient, and then you do a good discussion with the patient. And if patient wants fast forward treatment, that's a different thing. But if patient is accepting your treatment, but I'm sure patient would like your effort. I'm sure. And maybe this is how our practices will also become a little bit uniform, because one center works in this way and other center. So at least it will become a uniform thing. So I think it's an excellent thing, and thanks for bringing this to our knowledge, and I'm very thankful to you for bringing this point. Thanks.
You can take comments from Priyanka as well. So Priyanka is our person from Amritsar, and she's trained in reproductive medicine from Bloom Training Academy, Mumbai, under Dr. Nandita and Dr. Paisa. And she has also acquired other skills in IVF, and now she is practicing in Amritsar. And she also, we took her since we take every time 2 people from the ISAR Brigade. So this time Dr. Bharat Bhushan and Dr. Priyanka have been chosen, but somehow Dr. Bharat Bhushan could not join because of some problem. Dr. Priyanka? Yeah, would
Yes,
you like
ma'am.
to
Yes, ma'am. This is this side.
yeah, would you like to say something on the article? Since we had sent the article to you also, I mean, how
On
useful, what are your comments after reading the article in a very short this thing? How would you explain this article?
so, ma'am, so like I'm very thankful, first of all, that I've been selected as the ISAR Youth Brigade. It's my first time, and I'm like way too happy to express my feelings. And the second thing is, yes, ma'am, I've read. Ideally, I've not read the first topic, yeah, but second topic in short, I have read about the AMH, AMH in male and the fertility, affecting the fertility on that. So in that it is ideally in short it is said that somewhere AMH is a very important hormone blood test where it suggests that the if there is low AMH, it suggests that there is poor quality and poor motility of the sperms. So in general, in conclusion, this has been said. And if we go into details, first we didn't know that AMH has this much of role, but after reading the article, it is proved that AMH is a very important hormone. Ideally, we use it for females and not for males. Yeah, but here after reading the article, it is said that if we can do one AMH which is related to other hormones, as in FSH also, and if it can be included, it can tell you about the male fertility also, ma'am.
Right. So that is another
Yes,
something very new thing that has come up, ma'am. And we can also utilize that in our subfertile males doing the AMH. Normally, we do not.
Yes.
I have never ever considered doing a AMH in a male. So
Yes,
this is
ma'am.
this article gives a little sort of a thought into this the AMH in these fertile male, how low it is, and how would it then affect our treatment. So that is something we can also start taking into our considerations.
Jyoti, one more article if you can find out, because recently I went to AOFOG and there was one article and that was use of FSH in non-hypo males.
Use
Okay.
of in non-hypo male and 70 hydroxyprogesterone also role in male infertility is coming. ये एक ये आर्टिकल है इसमें जो है रिप्रोडक्शन जो रिप्रोडक्टिव जनरल.
Thank you so much, Asha ma'am, and it is always a pleasure to have you, have your inputs, and always have you on our platform. We feel so very connected to you, and we feel so very close to you. And your inputs are always welcome. And this platform, I would also like to thank all our ISAR brigade and the think tanks of ISAR, Dr. Ameet Patki sir, Dr. Nandita ma'am, Dr. Sunita Tandulwadkar ma'am, Dr. Madhuri Patil ma'am, Dr. Sujata ma'am, and Dr. Charudutt sir, and dear Dr. Keshav, alongside with Dr. Asha Baxi ma'am, for providing us this support system that we have always when we take up a topic. We know somebody or anybody out of you would be there to guide us. So thank you so much, ma'am, for always sparing a time for us. Thank you. And thank you, Jagsonpal, Dr. Deepika. You are our biggest support, as usual, always. Thank you, Priyanka, for being there, sharing the topic so well. Over to Deepika. Thank you, ma'am. Yeah.
Yeah, thank you so much, and thanks a lot to the attendees and the faculty today. This is an announcement that I'm making about recently launched women's health website that is a CSR initiative of Jagsonpal Pharma Ltd. This is mysakhi.in. As you are aware, Jagsonpal Pharma is one of the leading pharmaceutical companies in women's health, and we take this initiative as a part of our commitment to improve women's health across all stages from adolescence till menopause. So this is a website that we have made, mysakhi.in, for the lay public. This will cover the whole life journey of a woman from adolescence till menopause, but currently we have started work with menopause. And in this, they will find a lot of material to read, which will be scientifically vetted and will have backlinks to all the journals and all, so they can read about it. And like menopause being a taboo, people don't want to discuss it within the family and outside, and they don't go to the doctors for the menopausal symptoms that they are having. No management strategies are there, but they are not availing of those. So we are sensitizing the women and making them aware that this is also a stage that can be, treated. Go to your doctor and visit your doctor for this. So in this, they will find a lot of educational material. We'll be building a community for them. And currently we have started having, menopause related all public awareness webinars of half an hour for the lay public. It is just an interactive webinar that we have with them. We have had only about 3 till now, and the 4th one is now on this Friday. So every Friday we are having this. Besides, we make a lot of noise on the social media so that people get aware that yes, it is a journey that we should, enjoy embrace the golden years that are now coming up. It is not the end of life. So menopause, we are creating a lot of awareness. So you can all also join us in this, in our endeavor to, make people aware. You could also give your expert guidance and all. We also have a section in this where our lay public can look for the doctors. You can join us as an expert and give advice. So thank you all so very much. And
thank you so much. Thank you, Dr. Deepika, and thank you, Jagsonpal. And this initiative of mysaki.in is wonderful, and definitely we would like to always support and be in all this social messaging that we need to put across all our women. Thank you so much.
thank you.